Hello, everyone, and welcome to the first session of the Million Hearts Learning Lab. This is Session 1, Cholesterol Management, Optimal Use of Statin Therapies. For audio connections, if you have any listening issues, in addition to joining by computer, you can also join by phone using the audio setting or the microphone at the bottom of your page. Today, we will be utilizing the Q&A function instead of chat. So please put any questions or comments that you have into the Q&A feature, and we will respond to them either in the Q&A section or throughout the meeting, depending on what it is. To locate the Q&A feature, you'll go to the bottom right corner of your screen, and the button should say Q&A or have a question mark next to it. Make sure that when typing your question or comment to send to all, or choose just send and not send privately. Also, some other friendly reminders. Today's event is being recorded and will be made available to you. And all attendee lines have been muted. So you don't have access to your microphone or your camera. So please, if you want to interact with our speakers, use that Q&A function that I just spoke about. And now I'm going to hand it off to Meg Meter.
Great, thank you so much, Alyssa. I really appreciate it. So next slide. So welcome everyone. I am Meg Metter. I'm Director of Clinical Integration and Education with the Clinical Affairs Division at the National Association of Community Health Centers, and I oversee our Million Hearts work supported by the CDC. And we're really excited to offer you this new opportunity that we've developed. It's a mixed methods learning opportunity. So what that means is we're actually providing and offering an opportunity to have CME credit earned by doing a mixed methods approach. So instead of just a live webinar, there's a piece of it that's live. That's today. We're reviewing some content and offering a robust Q&A opportunity, assuming that you've done some pre-work. So we're hoping that you listened to an audio recording that's about 12 minutes and completed a survey that allowed you to submit some questions in advance. Don't stress if you haven't done this. This is our first iteration, and you can go back to our Million Hearts Learning Lab Confluence page, and you can access these and still get your CME credit. But we just wanted to share with you that this is a different way of getting CME. We're hoping it works better for you in terms of your time, in terms of offering different methods for learning. And you can see the link there. We'll be sharing that also later in this opportunity today. Next slide. So I want to introduce our speaker. Really excited. Dr. Kate Curley is someone who I've had the pleasure to collaborate with for the past 3 years on our Million Hearts work. She is Director of Chronic Disease Prevention in the Improving Health Outcomes Group at the American Medical Association. Prior to joining the AMA, she was a practicing family physician and health services researcher at North Shore University Health System, that's in Chicago, and is a clinical assistant professor in the Department of Family Medicine at the University of Chicago. She also served as Assistant Director of North Shore's Quality and Patient Safety Fellowship and as Assistant Director of the Ambulatory Primary Care Innovations Group, which is a practice-based research network. So really appreciate, Kate, your time and the opportunity to hear from you today and have you answer some really key questions that came in advance, and also the ones that we received today on this call. So Kate, over to you.
Thank you so much, Meg. I'm really happy to be with you all this afternoon or morning, depending on where you're coming from right now. Next slide, please. So as Meg noted, I'll start out by spending about maybe 10 minutes reviewing some content and just making sure we're sort of all on the same page before we launch into the Q&A session. We got some fantastic questions already from those of you who did your pre-work survey, so we'll start out by addressing some of those and get into a little bit more live Q&A too. So just a couple points to cover first. One thing that I don't think I had in our pre-work was just a basic idea that I want to talk about, which is that if we look at the more recent cardiovascular disease prevention-related guidelines that are coming out of organizations like the American Heart Association and the American College of Cardiology, what we see is there's this subtle paradigm shift that has happened over the past few years. If we think about cardiovascular disease prevention, sort of our old approach, the way many of us were trained, was to sort of identify patients who have high cholesterol and treat it, identify patients who have high blood pressure and treat that, identify patients who have diabetes, treat that. And really this paradigm shift, this way guideline writing bodies are encouraging us to think now is really to think more about assessing our patients' cardiovascular risk from a more holistic standpoint, understanding what their cardiovascular risk is, and then thinking about what tools and interventions and treatments we can offer them to help reduce that cardiovascular risk. And those tools can include things like statins and blood pressure medication, diabetes medication, also lifestyle therapy. So it's just a little bit of a subtle paradigm shift, but it does kind of influence how we go about caring for our patients. Next slide. And just to review very quickly, there's sort of an overall overarching approach within the ACC-AHA cholesterol guideline, sort of a stepwise process that we want to follow when we think about using statins with our patients. The first step is to assess our patient's risk, their overall cardiovascular risk, and determine if they fall into one of the main statin management groups. If we decide that our patient does fall into one of those statin management groups, our next step is to do two things at once. It's to both offer our patients lifestyle therapies as well as offer them appropriate intensity statins. So notice that that is not a sequential thing. We don't start by offering lifestyle therapies and see what they do and then offer statins if they're not successful with lifestyle therapies. We want to do those two things at the same time. And then we're going to monitor their response to their treatments. And for certain subsets of patients who don't respond as we perhaps would like them to, there may be some groups of patients where we consider using non-statin therapies, but that's really sort of outside of the scope of what we're talking about today. So that's our overall stepwise approach when it comes to using statins with our patients. Next slide, please. And just again, to remind you all, there's sort of two main groups of statins that we are thinking about or talking about today. There are our high intensity statins, which should on average lower LDL by 50% or more, and we really have two options in the US. And then there are also our moderate intensity statins, which are expected to lower LDL on average between 30 and 49%. And we have lots of options of those available in the US. And just take note that the statins that have an asterisk next to them are ones that have a longer half-life, and therefore we can actually administer them at any time of day. So, we're used to generally telling our patients to take their statins at bedtime, but if we use the ones that have a longer half-life, we can actually administer them whenever, whatever works for our patient's medication regimen. Next slide, please. And then really quick sort of thumbnail recap of what the guideline actually tells us. So we have four main statin management groups that the ACC-AHA guideline focuses on. The first one is the group of people with clinical ASCVD. So they already have atherosclerotic cardiovascular disease. This is our highest risk group of patients, and this is really about secondary prevention. Our second group of patients that we think about are adults aged 20 to 75 who have an LDL that is greater than or equal to 190 milligrams per deciliter. So these are people with severe hypercholesterolemia. They are also a high-risk group. Our third group in the blue box there is one of the primary prevention groups. This would be people with diabetes who don't fall into one of the above boxes and have an LDL that falls between 70 and 189. Most of the guideline focuses on people with diabetes of the age between 40 and 75. So that's where a lot of the recommendation kind of devotes sort of space, but they do talk a little bit about what to do with individuals with diabetes who fall outside of those age ranges. And then our fourth statin management group, I like to think of almost as the pure primary prevention group. So this is adults who do not fall into any of those other three boxes. and have an LDL between 70 and 189. And this is the one group where we need to do that 10-year ASCVD risk calculation before we can decide whether or not they are really in a statin management group, as well as which intensity statin we should use for them. So for the top two groups, those with clinical ASCVD and those with severe hypercholesterolemia, generally speaking, we're going to want to use a high intensity statin for those patients. And then for our bottom two groups, those with diabetes and those who have that 10-year calculated ASCVD risk between 7.5 and just under 20%. Generally speaking, we're going to be using a moderate intensity statin for those patients. However, if those patients have additional risk factors, so for example, if a patient has diabetes but multiple ASCVD risk factors, we will want to think about using a high intensity statin for those patients. Or if that patient is in that primary prevention group, however, they have risk enhancing factors like early family history of cardiovascular disease or a chronic inflammatory condition. So if they have risk enhancing factors, or if their 10-year ASCVD risk is greater than 20%, that actually makes them more of a high-risk person, and that's someone that we would consider using a high-intensity statin in. So those bottom two boxes there, you're either going with moderate intensity or high-intensity statin, depending on the risk of your patient. So that's just a really quick thumbnail sort of recap of the guideline and just a little bit of maybe level setting as we get into the Q&A. So go ahead and advance to the next slide. So we did, as I noted, we received several really good questions from the pre-work survey, and I've taken a look at those, and they sort of fall into a number of different categories, but we noticed that there were two sort of themes that came out in a lot of your questions. One was a number of questions that relate to adherence to statins. And then the other big topic was, how do we deal with side effects associated with statins? And it just so happens I have slides lying around that talk about those topics. So I'm going to spend a few more minutes using a few slides to try to answer some of those questions that we got. And then I'll actually hand it over to Meg, and she's going to help moderate more of a live Q&A with everybody. So hang with me for just a few more slides for a few more minutes here. So let's dive in and talk about non-adherence with statins in a little more detail. And of course, I think everybody knows that medication adherence is a huge challenge for all of us. It's a big issue within our country. And there are many reasons that patients may not adhere to their medication regimen. And when it comes to thinking about statins, there are also some statin-specific reasons that patients may not adhere to their medications. So for one thing, potential side effects, whether they're real or imagined, associated with statins is a big challenge, and I'm going to talk about that in more detail in a moment. Another issue that is somewhat unique to statins, or really maybe medications that we use for chronic disease prevention, is this idea of the nocebo response. So the nocebo response is almost like the inverse of the placebo response. And it's this idea that when we want to use a statin for our patients, generally speaking, their risk and their hyperlipidemia is a symptomless condition, right? So they feel fine much of the time. And the benefits of statins, the reasons we're encouraging our patients to use a statin, these benefits are somewhat abstract. They're not actualized in the short term. So benefits don't really happen until you're using your statin theoretically for a few years or so. It's a little tough to say how long it takes to benefit from a statin, but let's just say it's a little bit longer term. And oftentimes the benefits are just not observed by patients, right? Because they were feeling fine in the first place, and the statin is not going to make them feel better. So if anything, if they feel anything, it's likely to be sort of a negative experience with the statin. So they may feel like they're experiencing some side effects. And so that's essentially the nocebo response, this idea that you're taking a medication that's not intended to make you feel better. And so if you feel anything, you feel worse. And so that's a challenge for sure when it comes to using statins with our patients. It's very hard, as a patient to get yourself to take a pill every day when you don't readily see the benefits in your life. Another challenge that can come along with statins is the medication regimen. So we already talked a little bit about how many statins require patients to take them at bedtime. That may not always fit within the rest of their medication regimen. So if there are things that you can address there, that can be helpful. And then another challenge with statins is that there's a lot of misinformation and confusing information out there that our patients are hearing. So we are kind of always trying to combat some of that misinformation with good patient education, but it is a particular challenge with statins. Next slide. So how can you address non-adherence with your patients? The first step is really to look for it, to assess for non-adherence, and you can do that in some somewhat systematic ways, whether that's using adherence screeners or questionnaires. You can use things like pill count, so having your patients bring in their pill bottles and actually counting the pills that are left. If you get medication fill data, you can follow medication fill data. You can also look for sort of other contextual sort of red flags, things like missed appointments, or not getting patients not getting refills at the frequency that you would expect them to. But none of this is really a substitute for just good, open, non-judgmental conversations with our patients. One of the ways I tend to set it up is, I understand that taking this medication every day is hard. I'm not great at it either. So just make sure that you are, your patients understand that you're well aware that adhering to a medication is challenging. Make sure you provide opportunities for them to discuss things like side effects with you. Ask them about challenges like costs and other logistical issues. So just try to create that sort of open environment to have a conversation about this and keep checking in with them about this topic. Next slide, please. And when it comes to statin use, there's another tool that you have in your tool belt to assess for non-adherence. And that is the fact that statins of specific intensities should reduce LDL in a somewhat predictable manner. And so if you're prescribing a high intensity statin for your patient, you can expect to see that LDL drop by about 50% or more. And so if you do a follow-up lipid panel with your patient, 3 months, 4 weeks to 12 weeks after they start their statin, if you do that follow-up lipid panel and you see the LDL reduce by 10 to 20%, the first thing you should be thinking about is medication adherence and having a conversation with your patient about that. So the fact that statins reduce LDL in a somewhat predictable manner is a tool that you can use to also assess for adherence. Next slide. And then once you identify potential issues with adherence, you want to work with your patient to offer solutions. And there's no single silver bullet solution to medication adherence here, but there are a lot of potential ways that you can approach it. And generally speaking, using a multi-component approach to supporting medication adherence is more effective than just trying to do one single thing. And you sort of need to adapt it to what your patient's particular problem or problems are with adhering to their medication or what particular challenges they're encountering. So generally speaking, solutions start before you even prescribe the medication. You always want to use shared decision-making with your patients, both when you're initiating statins and to check in with them throughout. So, making sure you understand what their own goals for treatment are and adapting your plan with them to help them meet those particular goals. Definitely addressing the side effects issue is important for supporting adherence. We'll talk more about that in a moment. As I noted before, you can use the statins that have longer half-lives. So you can dose those any time of day, perhaps in the morning if it's a more convenient time and allows your patient to take it with the rest of their medications. Of course, goes without saying to you all, I know, but prescribe low-cost generics, be aware of your formularies and try to keep costs at a minimum for your patients. Now, some non-adherence can be due to forgetfulness. We tend to jump to that idea really quickly that, oh, my patient's just forgetting to take their medications. Oftentimes, non-adherence is actually intentional and oftentimes rational. But forgetfulness can be a part of non-adherence, and so you can offer some suggestions to your patients about how to deal with that. Things like reminders on their phone, pill boxes, placing their medications in a place where they will tend to see them and encounter them, getting the pharmacy to create a pill pack for your patients so that they can keep track of all their meds together. and make sure they know if they've taken it for a specific day. So those are all approaches that can support the forgetfulness issue. And then really, really important, shown to help with medication adherence is frequent contact with the healthcare team. I know everyone's really busy, especially right now. Many of us are overwhelmed. However, the more touch points you can have with your patients, check in about adherence, check in about side effect issues, especially right after they start their statin or you change their statin dose. Just that frequent checking in, whether it's an actual visit or whether it's a patient portal check-in, a phone visit, a telehealth visit, all of these approaches can be used to really support more contact with your patient, which can help with adherence. Next slide, please. So let's also talk about side effects for a minute, because again, this is a huge issue that we hear about with statins. I always get lots of questions about this. And patients hear about, a whole bunch of different potential side effects when it comes to statins. So oftentimes they go into, starting their statin with a mindset of being worried about encountering side effects. And we'll talk about muscle symptoms in detail in a moment. But you can see on this slide sort of that list of other symptoms or side effects that people might be hearing about and be worried about. When it comes to diabetes, new onset type 2 diabetes does appear to be a real, although rare, risk of statin use. Generally speaking, the recommendations are to still proceed with using that statin in a patient who is high risk for diabetes, or even a patient who does develop new onset diabetes. It's thought that the benefits still outweigh the risks in these patients. So you can counsel your patients that there is an increased risk. The risk is very, very small. And you want to offer your patients other supportive solutions like referrals to lifestyle therapies. So that is one side effect to be aware of. Liver problems is another thing that tends to be on the tops of our minds. Many of us were trained that we need to watch out for liver issues when it comes to using statins. However, now that we are decades into using statins with lots and lots of safety data about them, it's really become apparent that this is a very, very rare problem with statins. So actual hepatotoxicity occurs about 0.001% of the time. So it's so rare that we don't actually have to check and follow liver function tests with our patients. We don't need to get a baseline. The only exception to that really is if we're using statins in a patient with chronic liver disease, which you can do. They're the one group of patients where you may need to keep an eye on their liver. Otherwise, it's really not a concern. So it's not something that you or patients need to worry about. And then the other side effects on this list here, dementia, cataracts, cancer, you can be very reassuring with patients that the evidence does not show any association between statins and these side effects. And so these are more rumored side effects than true. So next slide. But let's talk about muscle symptoms a little bit more because this is the one that comes up the most. So serious statin-induced muscle injury is actually very rare, less than 0.1% of patients. However, patients report statin-associated muscle symptoms pretty commonly. In observational studies, about 5 to 20% of patients may report experiencing some muscle symptoms. It's important to note that it's really just muscle symptoms. So for example, there is no association between statins and tendinitis. It's just really the muscle aches and pains. And the way you want to approach dealing with muscle symptoms is, first of all, it starts before you even initiate the statin. So ideally, you want to assess for and document any aches and pains that your patient has before you initiate the statin. That way you have that sort of objective baseline that you can come back to and compare with later on. You do not need to automatically check a CK in everybody, a creatinine kinase in everybody who has muscle symptoms, only if they have severe symptoms or they have objective weakness. And then I really recommend the American College of Cardiology's statin intolerance tool. This is a tool that you can use with your patients in the room, and it can help you figure out if the symptoms they're complaining of are actually likely to be due to the statin, and if so, what to do next. So next slide, please. So in terms of what to do next or how to address side effects in general, like I already said, shared decision making before you start the statin is really important. You want to emphasize with patients that generally speaking, there's a low risk of side effects, but plenty of benefit to be gained from their statin. You want to make sure they understand that if they do experience a side effect, that this can typically be addressed and generally speaking, completely resolved. So you really want to encourage them to let you know if they're experiencing any side effects because you can work with them on that. You can generally speaking fix that, and you can generally find a statin that is still going to work for them. Again, you can use that ACC statin intolerance tool to really figure out if this symptom that they're complaining of is likely to be due to the statin or not. And if it is potentially due to the statin, again, that tool can help you figure out what to do next, but oftentimes it comes down to taking a break from the statin, seeing if the symptom resolves. If it does, and it's probably statin-associated, oftentimes, generally speaking, you are going to want to switch to a different statin and try to use a statin at the same intensity. So whenever possible, we want to keep our patients on the recommended intensity statin. And just because a patient experienced an issue with one statin does not mean that they will struggle with another statin. Most patients can find a statin that works for them. If their symptoms still persist at the recommended intensity statin, then you can think about trying a lower dose. The general thinking is some statin is probably better than no statin. So that is sort of the overall quick whirlwind approach to addressing both adherence and side effects, and hopefully that addresses a lot of the questions that we were getting in the pre-work. But Meg, why don't I turn to you now, because I know we got some other great questions, and hopefully we're starting to get some questions in the Q&A that we can start to address as well.
Thank you, Kate. So yes, absolutely. We got some questions that I think we can address from the Q&A. We have one already, and then we have a couple more that I would love to sort of field here, just because I know it's come up so often in our Million Hearts projects. But let's address the one in the Q&A. So Holly Biola said, is there an ASCVD risk calculator that takes into account Asians?
So that's a great question. The current ASCVD risk calculator that is widely available that we're all using really does not take race and ethnicity into account well beyond sort of Caucasian and African American or Black individuals. It is definitely a limitation of the risk calculator. Honestly, as is the fact that we're using race to try to predict risk as opposed to other more granular individualized risk factors, recognizing that race is a social construct and not a biological construct. So how do we sort of understand patients' risk at a more granular level? There are some challenges with the risk calculator. And that also is part of the reason why when we use the ASCVD risk calculator, it's important to recognize that it's only calculating risk based off of the risk factors that we put into it. So there are other risk factors that aren't captured by the risk calculator, like early family history of ASCVD, like the presence of chronic kidney disease or chronic inflammatory conditions that also influence our patient's risk. And so it's important that we both take a look at the risk calculation, but also think about those other factors that might be playing into risk as well.
Super, thank you, Kate. So definitely encourage those on the line today on the call to type additional questions that you have into our Q&A. I really want to make sure that we're addressing the things that are most important to you today. I do want to raise one though while we're waiting for your great questions to come in. So in my Million Hearts projects, I'm working with a group of people that are really focused on hypertension and then another project on cholesterol. And I think that's where the confusion comes in around lifestyle. So we know with hypertension treatment, for stage 1, you always start with lifestyle. And then if the patient progresses to stage 2, then you have medication as a treatment. And I think people have that sequential lifestyle then medication in their minds. But with a high-risk patient, Kate, can you explain, how that works with statin therapy in high-risk patients? Is it sequential, or is it different?
Yeah, good question. And I think another reason why a lot of times we hear about wanting to take this sequential approach with starting with lifestyle therapy and then considering the statin at that point is, frankly, a lot of our patients are kind of resistant to the idea of taking a statin. And so I think it's helpful to understand sort of the potential impacts of both. So, lifestyle therapy, so changes in nutrition and diet. When we look at the studies out there, they're potentially able to reduce LDL by, about 10 milligrams per deciliter, maybe generously, 15 milligrams per deciliter. Same thing if you look at physical activity, a lot of the study estimates are even a little bit lower. They may reduce LDL by about, 5, 8 milligrams per deciliter on average. And that's not to say that some people can't have more impact, but if you look at the studies, that's generally what you see. And so when we're thinking about the degree of ASCVD risk reduction that we are trying to achieve with these high risk groups of patients, it's very clear that statins reduce risk more substantially than lifestyle change. But lifestyle change is still so important. It has so many potential health benefits. We think of it as the cornerstone of managing sort of all ASCVD risks. So it really is about trying to use both of those approaches at the same time, but not expecting that lifestyle alone is going to achieve the type of ASCVD risk reduction that we could give our patients with statins.
Super. Okay, another question here, and I'm going to say it 2 different ways for the quality improvement and other care team members on the call that may not be familiar with these terms. So are there real differences in side effects between lipophilic and hydrophilic statins? So that's fat soluble and water soluble statins.
So, and I'll admit, this is a particular topic that I am not as well versed on. But if you try to look at, I get a lot of questions about, what's the best statin? If you had to pick one statin to start with, what should you go with? And if you kind of look across the literature, there isn't sort of a clear front runner. You'll hear different sort of anecdotal stories about which statins might be less likely to have specific side effects. But if you look across the literature, there's not really a real sort of clear leader there or clear particular situations where you want to try one instead of the other. I think the bigger take home is try something with your patient, try something they can afford and access. And then if you're running into issues, just think about trying other statins.
Super. Okay, I may mispronounce this, so correct me if I'm wrong. Dr. Curley, this question says, in the past, I've seen colleagues suggest CoQ10 for statin myalgia. Is that something you use?
So there is not great evidence, again, supporting use of coenzyme Q10 to deal with myalgias. So there's, this theoretical idea that they could, but it hasn't really panned out or been tested in the literature. I get questions a lot along those lines a lot, and some people say, well, isn't it probably safe? So can they just sort of try it if they want to? It's really hard to advise on that because I just don't think we have the evidence base to say, sure, why not? And I think when it comes down to it, we want to stay away from recommending something that just doesn't have a great evidence base.
Okay, and here's a 2-parter for you, Kate. So are there specific side effects that are associated with specific statins, or is it patient to patient?
That's very similar to what we were talking about before. Um, it's hard to actually say, this statin tends to have more of this and that statin tends to have more of that once you actually sort of look at all the literature that's out there, the range of literature that's out there. And I would say it's a little bit more patient to patient rather than statin to statin. And I think probably the bigger thing to think about statin to statin is actually potential interactions with other medications. That's probably something to think about more than specific side effect profiles.
Very helpful. And then a comment here, would you mind repeating what you said about half-life and taking statins at night versus morning?
Yeah, and it's back also in the slides in the pre-work, the slide that has that sort of lays out which ones are the high intensity statins and which ones are the moderate intensity statins. If you look at that slide, the statins that have an asterisk next to them are ones that have a longer half-life and can be dosed at any time of day. So you get flexibility there. You could have your patient take them in the morning as opposed to thinking about that take it at bedtime thing that we usually tell our patients to do with statins.
All right. Okay, here's another one for you. What does the evidence say about the use of Zetia, did I say that correctly, rosacea in high-risk patients who have serious statin allergy anaphylaxis?
Good question. So when we start getting into non-statin medications, which sometimes is hard to talk about without slides and other things to break it down, there are some specific subgroups of patients where if you are not able to achieve the LDL reduction that you want to see with a statin, and that could be because they can't take a statin, period, or probably more commonly it's because maybe they're not tolerating their ideal sort of intensity statin. There are some patients where you would consider adding ezetimibe or using ezetimibe instead if they truly are statin intolerant. These recommendations are probably a bit more evidence-based for our higher risk patient groups, like our patients who have clinical ASCVD. But again, we'll usually really prioritize the statin as much as we can.
Great. And then another here is, has diabetes always been an indication for high intensity statin?
So to clarify, so diabetes, age 40 to 75, many of those patients, a moderate intensity statin is going to be the recommended treatment for them. However, if they have diabetes and they have multiple additional ASCVD risk factors, essentially they're a higher risk patient, based off of their risk profile. Those are the individuals with diabetes for whom we would want to consider using a high intensity statin.
Okay, and there's a question here that I'm going to reframe a little bit for
Sure.
you. The question as it's posed is, at what age does it not make sense to start a statin for primary prevention? And I would also say, maybe you could say, when would you start a statin for someone under 40? When would you start one for over 75?
Sure. Yeah, and this gets complicated. So let's talk about the over 75 group a little bit first. And this is where we sort of get into what I'm going to call sort of softer parts of the guideline that involve a lot more sort of clinical judgment and shared decision making with your patients. So there is a recommendation to essentially offer a moderate intensity statin to people over age 75. Across the board, because age in and of itself is a significant predictor of ASCVD risk. However, then there are a number of scenarios where it may be appropriate to just forego the statin or even discontinue a statin in somebody who is already taking it. But generally speaking, there is a recommendation for statin use above age 75. And if your patient was already on a statin, they turned 75, they're doing well with it, keep it going. So situations where you may want to not use a statin over age 75 would be patients who, we're very familiar with them, have sort of multi-morbidity, frailty, extremely complicated medication regimens where interactions become more of a problem, limited life expectancy. So it's hard to draw a line in terms of how many years is a limited life expectancy, but something around the order of 3 years. Those are the types of patients where statins may really not be appropriate. And then you also have your other interesting group of 75 and up people who seem really healthy. And you see this recommendation that everybody over 75 should probably use a statin, and you think, they seem like they are lower risk than their age, makes them seem. That is a group of people where you can consider a coronary artery calcium score. You can get a coronary artery calcium score. If their score is 0, that means that you can reclassify those individuals as low risk and you can potentially avoid a statin. So the over 75 group is a little bit complicated. To turn your attention to the under 40 age group, what are situations where you may be using a statin? So just to say, to make it very clear, anyone with clinical ASCVD, statin is indicated. Adults with severe hypercholesterolemia, so adults with an LDL greater than or equal to 190, high intensity statin is indicated. And then for our patients who have diabetes, there are some situations where we might want to consider a statin at a younger age. Those mainly boil down to having their diabetes for a long period of time. So with type 2, that's probably about 10 years. With type 1, that's probably about 20 years. or already having evidence of microvascular disease. So already having kidney compromise, other evidence of microvascular disease would be a reason to consider using a statin in a younger patient with diabetes. That was a mouthful.
It's really important. I think these go along with a lot of the questions we received in advance. And so I just have one last one for you. I think we have time for one, and it's related. So are there special considerations for women of childbearing age?
Yeah, great question. So if you have a woman of childbearing age who falls into one of our statin management groups, there are a couple things that you want to consider. So one, she should be counseled to use effective contraception. So statins are a pregnancy category X medication. So we want to avoid situations where pregnancy and statin use are happening at the same time. If you have a patient who intends to become pregnant, and hopefully you find that out in ideal situations before she becomes pregnant, and what you want to do is stop that statin before she attempts pregnancy. If you do learn that your patient is pregnant while she is taking her statin, you do want to stop that statin as soon as you learn of the pregnancy.
Super. Kate, is there anything else that you want to share that you saw a question that was of particular interest that came in for the pre-work, or something that you thought of as a final sort of statement, question, sharing today?
There was a couple questions related to sort of the quality measures related to statin use right now. Sort of some questions about how good are those, how well do those align to the clinical guidelines. And I will say that the UDS statin measure, cholesterol measure, looking at statin use in high-risk groups, does align quite well to the current clinical guidelines. And I think it's a useful tool that we can use to understand sort of how we're delivering hopefully high quality care to our patients in these groups.
Super. Thank you so much, Kate. This was really informative, and I'm really excited that we're going to be able to offer the recording for your colleagues that may not have been able to attend live today. And we definitely want to give them an opportunity to hear this. Alyssa, if you could get us back to the slide deck, there are a few wrap-up items I want to share with this group. And while we're waiting for the slide deck to appear, my colleague Rita Lewis actually put into the Q&A the link to our Million Hearts Learning Lab site on Confluence. And that's where you can find everything to do with the Learning Lab. So you can find registration information, you can find the recording, the materials, and how to claim CME credit will also be on the Learning Lab site. So in case you don't want to go through and listen to the recording again, or quickly jot it down, you do have access to that on our Confluence site. So I just want to make sure people realize that. And we will be sending out an email afterwards, so you don't have to quickly even cut and paste from the chat if you don't want to do that. So how to claim CME credit. So there's a link here. We're actually in collaboration with the American Medical Association, NACHC, to put this opportunity on. And they are graciously hosting this opportunity on their EdHub site. So that's why you're going to click an EdHub link. Then you're going to sign in. If you don't already have an account, you can easily and freely create one. And then from the activity page, you're going to enter the session code, which is statin. You need to take a quiz that's common with all CME, and then select the appropriate amount of CME to claim, which is 1.0. And just to note, it's open until October 27th, so you do have some time. I definitely encourage, if you haven't listened to the recording and you haven't completed the survey, please do the right thing. The CME credit is for a full hour's worth of work, and so that would be including the pre-work and then today's live event. So just wanted to share that with you. Next slide. And then once you've logged in and successfully completed the quiz for CME, you click on your name, and located at the right-hand side, you can select transcript, and then you can download your certificate. So all of these instructions we're going to put again in Confluence. You'll have access to these slides so that you can use them for reference when you're trying to go through this for the first time. We definitely hope that you found this format to be helpful, and encourage you to register for the remaining events. We have four additional events. 3 are still in the works in terms of the planning, but we do know that our next one is coming up in November on the 17th, called Intensifying Treatment to Achieve Blood Pressure Control. You can literally hold your phone up to the QR code if you want to, to register, or you can get the registration information in the follow-up email that we'll be sending you. So thanks again to Dr. Curley for her great insights and information today. Thanks to you for your great questions in advance and your participation on today's call. Really appreciate this, and thank you so much. Have a great rest of your day.